Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. Welcome to this 10th episode of Polyp Gossip, where we share latest insights in what is really relevant to know about CRSwNP with key opinion leaders in the field coming from different horizons. And today we will be discussing the truth or the myths around systemic or nasal corticosteroids in the field of CRSwNP. And I'm very privileged to have here with me Professor Wytske Fokkens from the University of Amsterdam, the Netherlands, as well as Veronica Seccia from the University of Pisa in Italy. So thank you very much for joining us on a topic which is very relevant for all ENT doctors and even more so rhinologists in the field dealing with severe patients with CRSwNP. And of course, within the international guidelines, oral corticosteroids are still recommended for those who fail first-line care. And therefore, I have a first question to Professor Wytske Fokkens all about, can you explain in very simple terms what is the difference between oral versus nasal corticosteroids as far as benefits as well as harms are concerned?
Well, thank you, Peter. That's a very important question. Let's start with nasal steroids. Nasal steroids are produced in a way that they cannot be taken up into the body. So you can use a huge amount of nasal steroids, which is anti-inflammatory. Every steroid is anti-inflammatory, so against inflammation. But nasal steroids stay in the nose, and for that reason are very safe, and we can prescribe them every day for the rest of patient's life. That's absolutely safe. Oral steroids, on the contrary, have have better anti-inflammatory effects, are stronger than nasal steroids, but unfortunately, because they are taken into the body, have an effect in the whole body, not only in the nose and the lungs, but also in our bones, for example, or our vessels. So it's important to realize, and we have a lot of new data in the last 2-3 years, that we always knew that oral steroids had adverse events, but we also learned, well, 2 to 3 courses a year is fine. Our pulmonologist said, oh, that's okay. Now we know that even 1 course a year is already far too much and really harmful. And the bad thing is that the acute effects are usually sort of manageable and not that bad. But the long-term effects, and we often do not realize that the patient will have severe adverse events 20 years later after we started to give our treatment, can be very considerable.
So I would like to hand over to Veronica and ask, how do you explain to your patients the benefits of nasal steroids versus the harmful effects of oral corticosteroids? How do you deal with that kind of discrepancy in effects depending on the route of administration?
Thank you, Peter, for this question. It's very important to stress that aspect with our patients, especially when firstly diagnosed, because you have to transmit them the importance of having a drug that has some benefits and some harm regarding the route of administration. So it's very important that they feel keen and comfortable in using steroids locally, intranasally, every day, and this is the basis that we have to share with the patient, confronting them about the safety profile that we have from literature, of course, comparing that to the use of steroids systemically, especially when they use it without the indication of the health practitioner. We give them a drug that they see, they give them very quick release from their symptoms, and sometimes they tend to use it when they have some special occasion to gain smell back, to gain normal breathing from the nose, and in that case we have to warn them that that kind of use randomly, occasionally, can be very harmful, together with the systemic cycles that sometimes we prescribe.
So if I understand you well, prescribing a corticosteroid requires some time as well to inform the patient and maybe counteract the corticophobia, because in our region many patients have corticophobia, they don't want to use the steroids. Is that also a reality in your experience, Wytske?
Yeah, absolutely, yeah. You really need to explain, well, that message, you can put a bottle a day in your nose, is exactly what I tell my patients. You know, you really do not have to worry about side effects, and even less than in the lung, but because many of our patients also have asthma, so they're worried because in the inhaled steroid, a tiny little bit is taken up into the circulation, but for the nose it's really not an issue, and we cannot emphasize that enough, how safe nasal steroids are.
Mm-hmm. Yes,
along with that, they have to be warned again about the harmful of the side effects. So it is we have a corticophilia in our country, not corticophobia, towards the occasional assumption of corticosteroids. It sometimes leads to a significant amount of steroids if you count that in a year span. So sometimes they tend to be scared of something that you take every day, but they're not scared of like intramuscular depot corticosteroid that I still see that some patients get, and not scared of that pill, magic pill that sometimes they take.
This is really interesting because steroid injections have been considered obsolete and are not in any kind of international guideline of care. So it's striking that this is still part of the practice that you see in daily life.
That surprised me a lot, because even though there is some confusion about what's the cycle of systemic steroid, we're really clear on all our guidelines that depot steroids are forbidden, they have no utility, they shouldn't be used in patients, and besides that, I still see patients that get depot intramuscular injection of steroids for their CRS with WNP symptoms.
Could you just give an overview, Wytske, of where we stand in the international guidelines regarding recommendation of nasal versus oral steroids? Could be good to just remind our listeners about where we stand today and maybe have a look in the future and whether or not oral steroids will be banned from any guideline now that we have better options. So what do you think?
Well, I think in all guidelines there is the use of nasal corticosteroids, preferably with rinsing. So that's everywhere. And the oral steroids, I think the new data that we accumulated in the last few years on the side effects of also very limited amount of steroids will definitely change the way, and the opportunities we now get with biologics will change our advices. And of course we also have to realize that not everywhere it's possible to, and I think ideally you would say if you need systemic corticosteroids regularly, so say at least once a year, that's an absolute indication to go for a biologic. But if you think in international guidelines, we have to realize, of course, that that's probably not possible everywhere in the world. So,
do you think we underestimate the use of oral steroids in our patient population? And if so, why would that be the case?
I totally think that. I think that's the steroid assumption is like an iceberg. We see just a little bit of that, but we are not used as in asthma care to register all the steroids that the patient takes. Sometimes even the patient is not able to tell you exactly how many times did it take steroids. Now we're more prone to that. Now that we have biologics, we have an alternative to steroids. We always stress out that if they take steroids, they have to tell us how many steroids, when, for what reason, nose, smell, blockage, other type 2 comorbidities, and this is all very important.
Mm-hmm. in the lower airways there are initiatives where they have tried to document the times and the frequencies and the doses of steroid use, but in upper airway disease that has not come through as a concept. Should we go in that direction one day? What is your opinion, Wytske?
I think so. I really think, well, the first thing we have to do is really convince all our colleagues about the long-term side effects, because something you don't see, you don't realize. And as long as we didn't have the data, you know, I prescribed kilos of prednisolone in my life, and now I'm really sorry for part of that, because I just didn't realize how bad it was. But now we do realize. I think we're obliged to be much more precise in what we prescribe. And also, I think very important to consistently ask what others prescribe, because it's one course from me, and then next month one course from the pulmonologist, and the week after from the GP. And who else did prescribe you this sort of medication? So.
Yeah. Well, in the past, of course, we didn't have many other options of care. So in patients with persistent, uncontrolled CRSwNP, there was hardly any other option. So I understand you feel a bit bad about that practice, Wytske, but on the other hand, well, it was the reality that we were confronted with 10 years ago, whereas now we have more options. So how do you think that will change also the impact of chronic sinus disease on all the comorbidities and all that we see as a consequence of what has happened in the past?
Yeah, I'm sure that we will see what we already saw in asthma and other type 2 comorbidities, but that will arrive, I think, faster in CRS with WNP, because we already have evidences that considering biologic as a solid alternative, like a steroid sparing agent, is a really effective and modern and life-changing solutions for our patients. Absolutely. I think that this is going to change a lot. Besides that, we mustn't forget that it was a solution, but sometimes oral steroids ended their efficacy. And so the patient had really no alternatives in staying with a poor quality of life, not only from a nose point of view, but also from a lower airways point of view. So we are really changing their life and their health.
Mm-hmm. What were the most frequently reported adverse events you saw in your practice when oral steroids were still regularly prescribed for those suffering from severe disease?
Okay, I introduced the figure of the endocrinologist in our team, because we've seen that the bone metabolism was something that needed really to take care of. Because we see older patients, female patients exposed to high dose of OCS that had problems with bone metabolism, osteopenia, osteoporosis. And sometimes, not very often, especially in patients with a high exposure to OCS, more than 1 gram per year, I would say, just to have a measure, we also see random adrenal suppression, which is very rare to find, but when you find, you have something that can be really important for the health of the patient. So it's something that we look after selectively in our center.
Would you like to add anything on this statement?
No, I really think the bone metabolism is the one we most afraid of and not so aware of. I can really think that we should advise in a next guideline that every patient who had more than so much, I don't know an exact figure, but quite low, probably maybe 1 gram in lifetime, needs to have DEXA scans once in a while to check on osteoporosis and osteopenia. Because if you recognize that relatively early in the process, well, you can still with medication help against it. And so I think that's something ENT surgeons have to learn to do that.
Wytske, in your tertiary care center in Amsterdam, you see what we tend to call the nasal cripples from all over the Netherlands. And if I make an estimation of that patient population, I think you used to prescribe oral steroids in maybe 60% of those cases, or even more so.
Maybe more,
yeah. What is the percentage now when you evaluate now your practice? Would it have dropped to 5% of patients, in which you may also try to achieve an even better state of control, or what is your current estimation?
Yeah, well, I don't know exactly. I don't know, but will significantly reduced. I don't know to how far, but a fraction of what we used in the past.
Is that the same in Pisa, I suppose? Yes.
Yes, absolutely. We, for our activity, to see an OCS user, it's a red flag to do something. So now we really stressed out this concept, even though it's doing OCS for asthma, but it has also CRS with WNP, or the other, vice versa. It's something that gives us the input to do something for the patient.
Okay. If we think about the non-surgical options that we currently have for patients suffering from severe uncontrolled CRSwNP, there is oral steroids on the one hand, there are biologics on the other hand, and these two options have anti-inflammatory potential but also have disease-modifying potential. Could you comment on those aspects and to what extent you believe steroids do have or do not have disease-modifying potential, and there is a benefit of considering biologics beyond the adverse events of oral steroids? You know what I mean?
Yes,
yeah,
yes.
Can you comment, Veronica?
Yeah, it's something that we have really in mind when we choose a biological solution for our patients, because we know that these drugs are giving us the possibility to see remission in our patients, to see maybe one-day cure, which was something that we starting to see now because of their exceptional increase of level of control in CRS with WNP. That's something that we don't see in OCS user. Besides that, we see remodeling of their way, so we have a detrimental effect on choosing an OCS way to treat our patients, also from the pathology point of view.
Would you agree on these statements, Wytske, or you have some other opinions in relation to disease modification with biologics?
I'm not so sure.
Steroids,
I think also oral corticosteroids give disease modification, but we never use them in that way. But if you would give an oral steroid every day and it wouldn't give any side effects, it would probably have the same sort of effects on remodeling and control of disease, and but of course that's not an option, so it's a totally theoretical discussion. And of course what biologics now bring us is that it's not a theoretical option anymore, but daily practice, and it's fantastic. It's really fantastic to see patients suffering for 10, 20 years, and now there's something to really relieve their disease, and they say, I'm fine, I don't need you anymore. Well, they know they still need a few injections here, but...
Well, in many other medical domains dealing with chronic inflammation, and I think of rheumatoid arthritis, any inflammatory bowel disease condition and other conditions, oral steroids have been used in the past and are not so much anymore. Do we think we will go in the same direction with our new treatment options? And Veronica, what do you think? So where will we position oral steroids in the future? Will it become totally obsolete to consider them, or do you think like there may be specific cases with breakthrough symptoms where oral steroids might still be considered?
I think that they have still a place, which is limited to the beginning of the history of the patient. When we see that oral corticosteroid can be used at the beginning of the treatment algorithm to make an intranasal corticosteroids more efficient, more capable of giving symptom relief, maybe 1 to 2 times, but then when we see the history of the patient and we see that her relies a lot on oral corticosteroid, we have to introduce something more. That can be surgery, of course, or biologic, depending on the patient profile, the patient history.
Wonderful. Wytske, you would like to make a final statement before we close this 10th episode of Polyp Gossip?
Well, I think it's really important to realize that most of our patients do well with surgery and an occasional systemic corticosteroid. So it's not that now everybody will have a biologic next year. But if you, so in the near future, I think it will still be reserved for a limited group of patients. What is of course very interesting is to think about a decade period and how that will evolve, and whether we, when they're more accessible financially, whether we will prescribe that as a first-line treatment because it's so effective. But for this moment, I still think for many patients it will be surgery and an occasional course of systemic steroids. And that is effective also.
Would your patients in PISA also appreciate that kind of approach
Yes.
on the short term?
Yes, I would say so. I really agree with Professor Fokkens. Surgery is still a very effective weapon against CRS with WNP. It gives a long-term relief from symptoms. It helps us selecting the patient that really needs biologics, so we still provide the surgical solution to a lot of patients.
Well, the guidelines also recommend surgery first, and the indication of a biologic in case symptoms recur. I think there are so many factors that predict success of revision surgery versus prediction of success of any other medical treatment. So I think the future is bright anyhow. So if I summarize what we have been discussed here, we all recognize the adverse events of oral steroids. We try to limit their use. We share the excitement of our patients that we have more treatment options that seem to be very effective and that reduce the need for oral corticosteroids. So I think the future is bright, especially with our patients being more satisfied and being less prone to the development of adverse events. So I think that's really good. So, and that's maybe a nice statement to end this 10th episode of Polyp Gossip. I thank you, Veronica, as well as Wytske, for your time, for your commitment to join us at this wonderful initiative. I'm sure that most of our listeners will have enjoyed this episode as much as I did. First of all, I thought this topic is a bit boring because we all know these adverse events, and we have been trained with these adverse events during our medical school. But now it's good to remind us of the harm. It's good to remind us of the future position. We want to invite you to also join us for the future initiatives of podcast series Polyp Gossip, where we are now thinking of the next topic, and please join us for the 11th edition, whenever that may be in the near future. So thank you so much, and enjoy the rest of your day.
Polyp Gossip. This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.